Okay, so this morning I will cover the continuation of the scrotal pathology. You remember that scrotal pathology we were discussing you can differentiate into two groups. One is a extra-testicular and intra-testicular. The extra-testicular means the pathology, whatever the pathology it is not touching the testis. It is extra-testicular. So what are the structures we can scan and we can see extra-testicularly? So most common things that extra-testicular, you can see the skin, then you can see the scrotal sac. Okay, and you can see the epididymis is outside the testis, but you can consider as an extra-testicular. Okay, so now in the skin, what are the diseases can happen in the skin? Edema. What else? Eczema. What else? Psoriasis. What else? Infection. You can see abscess. Okay, so skin, can we see the skin in the scrotum? In the image? Yes. Do we measure the thickness of the skin? Yes. So now, if you see, look at here, all of them can cause thickening of the skin of the scrotum. And what is the normal? I told you before that it should be below or less than 5 millimeters. Okay. So now we can easily evaluate the skin by looking at the image. When there will be edema, then you will see that it is thick and it is hypoechoic. Then eczema, infected eczema, non-infected eczema, dry eczema. Psoriasis, these are dry, scaling, a lot of dead tissues you can see. But there will be a lot of fibrous tissue development. And when there will be infection, then you will see the color, dolor, rubor, tumor, functionalisa. There will be hypervascular, thickening, redness, pain, and if there is an abscess, then you can see there is a collection of pus, right? So now, in the scrotal sac, what are the disease? What are the situation you can see? Remember, the scrotal sac is a tunica vaginalis sac, because it is the abdominal peritoneum that is going inside the scrotum through the inguinal canal. When it goes into the scrotum, its name is tunica vaginalis. And tunica vaginalis has a parietal layer and visceral layer. And between those two layers, the potential space known as scrotal sac or scrotal space. And this scrotal sac is outside of the testis. And this scrotal sac can be filled with materials. So it could be, scrotal sac could be filled with fluid, we call it hydrocele. Okay? And this hydrocele can be congenital. Congenital. And it could be unilateral or bilateral. It could be small, it could be big, and it contains fluid. And this fluid could be different colors. Let me give you an example. If this scrotal swelling contains blood, we will call it hematocele. If it contains pus, we call it pyocele. If it contains lymphatic fluids, we call it lymphocele. Okay? So now it could be filled with malignant fluid. Somebody has a cancer, and there is a fluid collection. So malignancy, so we call it malignancy can cause hydrocele. Keep that in mind. This fluid containing, this fluid, hydrocele is a fluid collection. But what type of fluid? It could be this. And another way you have to know that fluid could be transudative could be exudative. Now what is transudative? Non-infectious. Exudative means with infection. Example, so orchitis, epididymitis. When there is an infection, there is a collection of fluid, that is called exudative. But other than that, those are known as transudative. Okay, exudative also you can include the malignant fluid, because the exudative fluid are dirty fluid, infectious fluid, and transudative fluid are usually non-infectious due to organ failure. if somebody has a heart failure, liver failure, kidney failure, bone marrow failure, then what happened? The whole body is filled with water. Anasarca. That people, they have swelling of the scrotum with fluid. And that fluid is clean fluid because it is a tangulative fluid. Okay, I just give a little more so that you can cover it in abdomen. If there is a ascites, they might ask you what could be the differential diagnosis. If there is a fluid collection around the kidney after surgery, what could be the differential diagnosis? You can fit all those everywhere in the body. Okay, so now if it is infectious fluid, if it is exudative fluid, then what gonna happen? You will see the signs of infection. Signs of infections. What are the signs of infection if it is exudative fluid?
Fever. Highway.
Color, dolor, ruboti, more functional. Patient will complain, high fever, pain, local temperature is hot, warm, congestion, and organ will be swollen, enlarged, and lack of function. Okay, and WBC count will be very high. So in that way we can exclude by taking the history and blood work that what is the cause of this hydrocele. And if it is a tangulative, so then you will see there is a others associated disease along with this hydrocele. Now sonographically, this hydrocele, how does it look like? Sonographically, this hydrocele, sonographic appearance, anechoic or sonolucent. So you will see there might be a small fluid collection, or there might be a whole scrotal sac is filled with fluid. Then you will see the testicle is brighter, clean or clearly seen, but the background is dark. That's why you can see everything, even though you can see the appendix testis, appendix epididymis. You can see that too. Okay? So now, epididymis, if you consider that epididymis is extra-testicular, means not within the testicles, but epididymis is covered along with the testis. So, epididymis could be extra-testicular. It depends on how you want to see. So, epididymis can have infection. We call it epididymitis. And epididymitis can cause acute, can cause chronic epididymitis. If there is an acute epididymitis, then what's going to happen? All patient complain, pain, temperature, swollen, edematous, congestion, and lack of functions, right? Yes. So all those things you can see, and also there will be reactive fluid collection in the scrotal sac. Okay, the scrotal sac, one can be hydrocele and other, look at here, the other one would be hernia. One is hydrocele, another is hernia. And what is hernia? Abnormal protrusion of one organ or one tissue or part of the tissue through an normal or abnormal opening. That protrusion is abnormal. It's not supposed to go down through the tunnel. Inguinal canal communicates with the pelvic cavity to the scrotum, right? So now, through the inguinal canal, if the omentum, the fat layer, the mesentery, omentum and coils of intestine are passing through that inguinal canal and goes into the scrotum, it is called inguinal hernia. And that inguinal hernia could be unilateral, could be bilateral, could be incompleted, could be completed, and could be indirect hernia, could be direct hernia. So many things can happen, but result is swelling of the scrotum. Swollen of the scrotum. And this hernia is mostly inguinal hernia. And this inguinal hernia can be reducible and irreducible. Reducible and irreducible means once it is herniated, usually it goes back when the patient is lay down, right? It goes back. If my inguinal canal is open and I'm standing and I'm bearing down, what happened? There will be herniation into the scrotum. Then when I'm lay down on the bed, then it gradually, the hernia disappeared. That is called reducible. But it could be irreducible. That is the emergency. Irreducible or obstructive inguinal hernia. That time you will see the patient came to you. Patient came to you for ultrasonography. So now give me the idea in hernia. Let me give you the diagram. In hernia, so this is scrotal sac and this is inguinal canal. This is testicles and this is epididymis. So now through this inguinal canal, the fat or the bowels are coming down. Okay, when it's coming down, it depends, the appearance depends on what is this. If it is a fat, if it is the intestine you will see the peristaltic movement, right? And the wall of the intestine, you will see the multi-layer. If it is a fat, the fat echogenicity you will see. So now this will come, say this is okay, so these things will come and look at here. You will see other than testis, epididymis, there is something in the, and take the history from the patient that he is having this situation for a couple of years. Every time it come down and it goes back. But this time it didn't go back, it's obstructed. Okay? You found that there is bowel. And you can prove that this is hernia, intestinal hernia. Okay? So hernia is another cause of scrotal swelling, scrotal pathology. Okay? So this could be unilateral, this could be bilateral. So now I will discuss about the intratesticular pathology. Okay, intratesticular pathology means this is a testis, and this is epididymis. So this is testis, this is epididymis. This testis is covered by tunica albuginea. It is covered by tunica albuginea, and that tunica albuginea also extended to cover the epididymis. Okay, so now, so this is tunica albuginea. This testis, we know, this testis has reti testis, and this testis has chambers or compartments, and within these chambers there are seminiferous tubules, 1 to 4 seminiferous tubules each chambers, and seminiferous tubules get dilated here, making the reti testis. Reti testis. And this, from this reti testis, the afferent ducts, they are entering into the epididymis, and finally they form the vas deferens. So now you have to understand there might be pathology of the seminiferous tubules. In the cross sections we learned it before. These seminiferous tubules can have pathology, and because it has cells, okay, it has spermatogonia, it has Sertoli cells, and in between the seminiferous tubules there is a cluster of cells. These cells are Leydig cells. Lytic cells. Okay, so there are different types of cells, means there are different types of disease. Where is it? Intratesticular. So just study it in this way, you will never forget. So now, okay, sperms will produce from here, and then mature sperms will be in the center. Okay, so now these seminiferous tubules make a net here, we call it retitestis. And this retitestis area also connected with mediastinum testis, because the retitestis is the dilated seminiferous tubules those form a net on the posterior aspect of the testis, and this retitestis needs support because this is dilated. Why dilated? Say thousands of seminiferous tubules are joining together. Now you can estimate how heavy it is. That's why it needs a framework for support. That support is connective tissue framework that is called mediastinum testis. Okay? So now look at here. These tubules making the vas deferens. So this is vas deferens. So I'm giving this idea that why I am going so details. Look, any obstruction, you have to understand, if there is an obstruction here, don't you think there will be total backup? When there is a backup, so then what happened? This retitestis area, you will see, let me show you. If you see, within the testis, there's a dilated tubes. What is this? This is seminiferous tubules ectasia. This is ectasia. You will be surprised. Oh my God, what is this? Looks like a wavy and dilated. These are the ectasia of the seminiferous tubules. Why? Because there is a backup. Why there is a backup? There is obstruction. Okay, so now my question. If this patient has a vasectomy, sometimes vasectomy people will come to the doctor to complain, doctor, 10 years before I have the vasectomy, but now I am feeling something like a bump into my scrotum. What is this? Then you have to take the history. That means due to the vasectomy, say this part is absent, right? And is tight. Sperm is producing, but that sperm cannot pass through. So as a result, backup, and because of the backup, there's a dilatations of the tubules. Not only dilatation, sometimes you might see a cystic area